All right, so this is Unit 3. It's actually 3A, 3B, and 3C. It's on common childhood illnesses. If you've ever had a child, known a child in daycare, anything like that, they've probably all had these, so it should be a review. There are only 3 questions on the test from these sections, so I'm going to kind of try and fly through them again. So otitis media, ear infection, it is an inflammation of the middle ear, and it may be precipitated by a URI. And what happens is the URI causes the ear tube to be inflamed. So then the air that typically flows through the ear is blocked. And so fluid is pulled into where the air usually is, which results in the pooling of that fluid in this warm area that creates an infection. You can read the common causes. Other causes of it that are not, S. pneumonia, H. influenza, cleft lip and cleft palate can cause it. Down syndrome, they're more likely to have ear infections. If you have enlarged adenoids, you're more likely. If you use a pacifier, if your parents smoke, or if you're in daycare, all of these can contribute to your likelihood of developing an ear infection. So manifestations, ear pain, which typically results in the child pulling at the ear if they cannot verbalize that their ear hurts. They're probably going to be irritable. They're going to maybe have some diarrhea and vomiting. They may not take a bottle or food as much because their ear hurts. And some of them may have a fever, so you would want to treat that with Tylenol and Motrin. They may wake up crying in the middle of the night. We used to get in the pediatric ER, people call 911 freaking out because they couldn't get their baby to stop crying in the middle of the night at 3 a.m. and they had a fever and they had an ear infection. And some may actually be asymptomatic, which is why, even as an adult, every time you go to your primary care doctor, you're going to have that ear exam. Basically, the way to diagnose it is to look in that ear. You're also going to do an HMP, but the gold standard is look in the ear and see what that membrane looks like. Let me see. Reflective light is good. If it's dull or red, that means it's probably got an infection. Treatment. So if you're less than 6 years of age, you're going to get an antibiotic for 10 days. If you're greater, you're going to get an antibiotic for 5 to 7 days. Typically, you're going to get amoxicillin as the first line, and then Augmentin second, and then if you're allergic to amoxicillin, you're going to get cephalosporin second generation. Follow-up will be needed to make sure that the antibiotics cleared the infection. And there's a question on here about why do we wait a few days to start antibiotics in certain cases. So I'm going to see if this works. I'm going to exit out of there. And according to NPR, I think you can see my screen, in the American Academy of Pediatrics, it's very interesting that about 70% of children would actually get better on their own within 2 to 3 days if we did not get them an antibiotic. And about 80% are better within a week to 10 days. So, as a parent, if you can deal with treating the fever and you can deal with them waking up in the middle of the night, then you may prevent them from being on an antibiotic. And so we're creating these super bugs, but we're also, there are issues with antibiotics for children. GI distress, and other things like that. So even working in the ER, there were some doctors who would want to wait and not treat them with antibiotics. Some other older school doctors thought, well, they're here and they have an ear infection, we might as well just go ahead and give them an antibiotic. So that may be something that you see a change in your nursing career. Like I said, treatment for it, you want to give Tylenol or Motrin for either the fever and or pain. You may give these things called Aralgan, which basically numbs the ear canal and gives them some temporary relief. You probably don't want to put, it's a hard call. Some people put cotton swabs in their ears after they give the Aralgan so that it doesn't run out. However, a lot of times the Aralgan tends to absorb all in the cotton swab and not actually in their ear. So if you can get them, if you can put it in and get them to kind of hold their head that way so that the medicine gets in that ear really good, that's the best way. You do not want to give decongestants or antihistamines. Neither have been proven to be effective. And actually, decongestants, if you give them to children young enough, have been known to cause abnormal heart arrhythms. So you definitely don't want to do that. There is a little section on the test about otitis media with an effusion. What you need to know for that is that means that there is fluid in the middle ear without inflammation. You do not treat these with an antibiotics. They are most commonly associated with hearing loss. So if for some reason you notice that your child is no longer hearing as well, you would certainly want to go to the doctor. And like I said, you don't want to treat them with antibiotics. But you would want to treat with, Tylenol or Motrin or something for that pain. And it's usually gone, I think, within about 3 months. All right, so otitis externa is inflammation of the skin and the surrounding tissue of the ear. It's also known as swimmer's ear. It can also, in addition to swimming in the warm months, can be caused by Q-tips, which is why you're told to never clean your ears with Q-tips. And those little toddlers that like to stick foreign items in their ear can also be caused by that. External drainage might be noticed, and they may complain of pain and itching. You want to irrigate that canal with some normal saline or something like that to get some of that debris out of there. I will tell you, when you irrigate an ear, you will be amazed at the amount of wax and buildup that comes out of those ears. Trust me. You can give steroid ear drops that help to decrease that inflammation. And antibiotic ear drops, you're only going to give them if bacterial infection is suspected. So that is not in every case of otitis externa. Moving on to section 3B. The pages in the course pack are wrong. These are pages 440 to 445. Again, if you've ever had kids that have been in daycare, they have had pink eye. I know somebody who had it as an adult when his daughter got it in daycare, and it was not fun. So basically, it's an inflammation of your conjunctiva, and it can be caused by many things: bacteria, viruses, allergies, trauma, or irritants. So what's going to happen with this? You're going to have some swelling of the eyelid, red conjunctiva, enlarged lymph nodes. that swelling is going to be very present in the morning, and the yellow or white discharge is going to be so thick in the morning that you probably are going to have to get a warm washcloth to wipe it away. And your child may complain of itching or burning eyes. And usually their sclera is red all the time, which is obviously not normal. It does make these children uncomfortable while they have it. You are going to diagnose based on symptoms and history. And you can look in their eye. You're probably not going to see that drainage, but you may see that red conjunctiva. So the treatment for that is antibiotic eye ointment or drops, which are fluoroquinolones. This is another one that can be a little controversial on whether we're just throwing antibiotic eye ointment at everybody who comes in, because if it's viral, which we never culture these children, but if it's viral, you just do a warm, clean cloth and it'll be gone in 2 to 3 days, as opposed to putting them through ointment or drops and potentially spreading it to the other eye or to other children. Again, that may be something that might change in your practice. And section 3C is atopic dermatitis, aka eczema. If you've never seen eczema, it can range from just a couple of bumps to very, very severe, and eczema can flare up pretty quickly as well. So it's a chronic inflammatory skin disorder. They're going to have intense itching, and over half of children that are affected develop it during their first year of life. They may also have other allergies, and it affects about 20% of infants. So about 1 in 5 infants is going to have eczema. A lot of them will have what we call baby eczema, and they just have it while they're an infant, and then they kind of grow out of it. Causes, genetics. Does anybody else in their family have eczema? Any siblings? The environment. Are they having like irritants in the environment and things that are going to flare up their eczema? Do they have a decrease in their skin function? Is their immune system responding to it? A lot of times when they scratch it, it damages that skin barrier, so your skin no longer can protect the rest of your skin from any germs and gross stuff that gets up under there. So all of these things can lead to a flare-up of eczema. How it looks is you're going to have these papulovascular lesions, and you're going to have drainage and exudate and crust, and it's not very pretty. The locations are kind of depending on the age. Like, diapered kids aren't going to tend to have it in their diaper region as much, but a lot of kids or infants that are in diapers will get it in their skin folds, like in their elbow creases or behind their knees or places like that. You can read the rest of that. Oh, sorry. The way you diagnose it pretty much is with an HMP, and you're going to obviously look at their skin. Treatment, there is no cure, but you can treat it. Right after bath, you're going to want to apply some cream. Most likely, what I have seen is you just lather them up with Vaseline and just make sure that that Vaseline is going to help to kind of keep that skin moisturized. And you may have to apply Vaseline several times throughout the day. They also may do topical steroids that help to decrease the inflammation. If it gets really, really bad, they may do oral steroids, but that obviously has a lot of side effects and is not something that they can do for the long term. So they don't like to do it because it makes it better and then it just comes right back and may sometimes come back worse. They may prescribe antibiotics if these areas get infected. And tacrolimus is an immunosuppressive drug. It is topical, and so it helps to kind of keep all of that inflammation at bay. The best thing you can do is to decrease any triggers that you know may cause the eczema to be worse, and then antihistamines may decrease the itching. So that is all. Let me know if you have any questions.